Hi, my name is Dr. Luciano Costa. I'm a myeloma physician at the University of Alabama at Birmingham. At this recent ASH, I had a chance to show the primary results of the master trial on behalf of my colleagues from the COMMIT Consortium. So this trial employed a quite modern combination of myeloma drugs, daratumumab, carfilzomib, lenalidomide, and dexamethasone, or what we call DARA-KRD. And all patients received DARA-KRD for 4 cycles of treatment, followed by autologous transplant. And what was different and perhaps innovative about this trial is we use consolidation on an as-needed basis, utilizing MRD for guidance. So patients could receive non-4 or 8 cycles of DARA-KRD consolidation. But if the patients had 2 consecutive MRD reads, then they transition to a phase that we call MRD sure, where they are monitored with regular blood tests and periodic bone marrow MRD, but they are not on maintenance therapy. So this gives the patients a path for treatment-free observation. Patients who did not reach that milestone went on standard of care lenalidomide maintenance. This trial was also different because it had an enrichment for patients with high risk. So intentionally accrue more high-risk patients. Despite being a treatment that includes transplant, there was about 20% of people who were older. There were patients, a quarter of patients of racial ethnic minorities and about 20% of patients who had a high performance status, which means they were sicker at the time of their enter the study. And we also going to present the results in terms of risk with patients with 0 high risk abnormalities or standard risk, patients with 1 high risk chromosome abnormality or high risk, or patients with 2 or more high risk abnormalities that we call ultra high risk. And what you can see is that for the primary endpoint, there was minimal residual disease negativity to 10 to minus 5, which is the standard international criteria. That was achieving 80% of patients and was similar, around 80% across all the 3 risk categories. In the deeper level of MRD that we call 10 to minus 6 was achieving 2/3 of the patients and was less common and took longer to achieve among those ultra high risk patients. Overall, we have that 71% of the patients were able to have 2 consecutively negative MRD reads and went into this MRD sure, this observation without treatment. Here we have the results after 2 years. 91% of the standard risk, 97% of the high risk, and 58% of the ultra high risk are without progression, and 176% of those patients are alive. When you look at those patients who cease therapy because they became confirmed MRD negative and when on monitoring, after 1 year, less than 5% of the standard risk and the high risk patients have had reappearance of the MRD versus 27% of the ultra high risk patients who had reappearance of the MRD or progression. So in summary, what we found in this study is that first and foremost, it is possible to do MRD response adaptive therapy. That was done in 96% of the patients in this trial, and the vast majority, 71%, achieved that MRD sure phase. The patients who have standard and high-risk myeloma, they have similar depth of response and a low risk of reappearance of the MRD or progression following this treatment plan. The problem remains, however, on the patients who are ultra high risk. Those patients, we need to explore novel therapies, particularly among the ones who don't achieve and sustain a deep response. And perhaps most important is that quadruple therapy in the achievement of MRD negative enable exploration of treatment cessation and monitoring as an alternative to continuous therapy, which has the potential to greatly affect the quality of life of the patients with multiple myeloma.